Our next speaker is Dr. Joe Putnam, who is a professor of surgery and head of thoracic surgery at Vanderbilt. He's going to be speaking to us about indwelling pleural catheters.
Thank you. It's indeed a pleasure to be here today, and I certainly appreciate the opportunity to discuss indwelling pleural catheters with you. Approximately 25% of pleural effusions in a general hospital setting are secondary to cancer, and 30 to 70% of exudative effusions are secondary to cancer. We do know that in these patients, 50 to 60% are positive on the first thoracentesis. Even after repeat thoracentesis, there are a significant number in whom malignancy cannot be confirmed by pathology. Thoracoscopy, however, is diagnostic in 92%. If a diagnosis is indeed negative, thoracentesis is certainly appropriate. Thoracoscopy does have a higher degree of accuracy. This is the problem that we are faced with frequently. Patients with large malignant pleural effusions, secondary to types of cancer. The patient has significant dyspnea. You have thoracentesis, it recurs. Repeat thoracentesis, it recurs. The patient continues to be miserable, and the clinician, whether it is a medical oncologist or surgeon, tends to want to treat this patient with a definitive therapy. This type of therapy can be quite simple or quite complex. Of course, one needs to have a free-flowing effusion for pleurodesis to be successful. With a free-flowing effusion and complete expansion of the lung, pleural apposition can occur and subsequent pleural symphysis. The median life expectancy in these patients is quite limited. So to have the patient hospitalized for 5, 10, 15 days while a chest tube completes drainage or pleurodesis is attempted can be a significant fraction of the remaining life expectancy. Lung cancer, whether non-small cell or small cell, has a 3 to 4 month median survival. Breast cancer, ovarian cancer, and although not shown here, lymphoma, have longer survival periods. In 417 patients in this study from 2000, median survival were 4 months, and these patients were viewed as optimistic candidates, as all were undergoing therapy of some sort. The most important predictor was the primary tumor, and one can see here that median survival of 3 months for GI primaries lung cancer is typical. Patients with breast cancer, mesothelioma, tend to have a longer survival. The treatment goals are to relieve or eliminate dyspnea, to optimize function, minimize or eliminate hospitalization, and reduce cost. Pleural symphysis, pleurodesis, is not necessarily a treatment goal. If one focuses on a patient-centered response, relief of dyspnea and improvement of function is the critical goal, not pleural symphysis or pleurodesis. The treatment options are multiple, including thoracentesis, whether single or multiple, chest tube alone, or with sclerosis, thoracoscopy with pleurodesis using either chemical or talc irritants, a chronic indwelling catheter, which I will discuss today. Pleuroperitoneal shunts have been used but are somewhat challenging for patients to manage at home, and others that are more historical, such as complete pleurectomy. The problem with sclerosis, as I mentioned, is that the end point is pleural symphysis, not the relief of dyspnea. The patient comes to you with a problem, which is dyspnea, not requesting pleural symphysis. When one considers the cost involved with hospitalization, the operating room, agents that are used, such as bleomycin, or the cost of the procedures, and the associated hospitalization and medical care costs, it can be quite extraordinary for a patient with these end-of-life procedures. Early observations noted that indwelling Tinkoff catheters, when placed for these malignant pleural effusions, were associated with spontaneous pleurodesis. In other words, the Tinkoff catheters were placed, the fluid was drained, several drainages were performed, and some patients had complete resolution of the effusion, pleural symphysis, and the catheter could be removed. The hypothesis was that a pleural catheter could be beneficial in that outpatient management could be accomplished, quality of life could be enhanced and allowed to persist. medical costs would be reduced, and potentially spontaneous pleurodesis could be achieved with removal of the device. This is the device that I'll talk about today. It is this is the Pleurex catheter. It's manufactured by Denver Biomedical. This is a silastic catheter. As you can see, there are three components to the catheter. This internal portion of the catheter with fenestrations allows fluid to enter. This polyester cuff is placed 1 centimeter within a skin tunnel, and this valve, a Cook catheter valve, one-way valve, where it can be accessed with a specific obturator and the fluid drained. So this portion is inside the patient. This is the skin protector, and this is external to the patient. This is the vacuum bottle that's used at home. This comes pre-made with the vacuum inside. This obturator is placed into the valve. The clamp is opened, and the vacuum is allowed to withdraw approximately 600 cc's of fluid. The indications are dyspnea from primary or recurrent pleural effusion associated with neoplasm. The contraindications are mediastinal shift, suggesting collapse of the lung, negative pressures, a multiloculated pleural space where the fluid cannot be completely drained, although potentially simple drainage of a single large loculation could be achieved. Patients with coagulopathy, pleural space infection, or chylothorax are also not recommended for use of this device. This is the treatment effect before and after a catheter placement. One can see the large pleural effusion here, and in this patient, the catheter, I believe, is here, showing resolution of the fluid and some relief of the patient's dyspnea. A phase 3 trial has been completed, a prospective randomized multi-institutional trial. This was in 11 centers, examining the concept of a chronic indwelling pleural catheter versus chest tube and doxycycline sclerosis. The reason talc was not used in all these centers was because talc at that point was not available for all. The purpose was to compare effectiveness and safety with the two devices. The sample size, let me just say that, let's go to this line right here, that 28 patients per arm would provide an 80% power. To increase statistical power and to compensate for an unbalanced design, a 2-to-1, 40 patients in the chest tube and sclerosis, 80 patients in the Pleurex catheter arm as minimal numbers were elected. This was the population. 99 patients underwent placement of this Pleurex catheter. 31% underwent chest tube and doxycycline sclerosis. These patients were, the advantages were that these could be done as an outpatient procedure, although for the purposes of the protocol, they were kept in-house overnight. Typically it's done on one side, but one can consider two sides. Local anesthesia is all that's necessary, although conscious sedation could be used. Monitoring ranged from nothing to continuous blood pressure, pulse oximetry, heart rate, and rhythm. Drainage approximately 20 to 30 mils per kilogram. And the outcome is typically a cough and pleuritic chest wall pain. Cough as the lung expands, pleuritic chest pain as the parietal pleura is irritated. This is the placement. This is the patient's feet here. The head is in this direction. This is the left chest. A needle is placed and fluid is obtained. A wire is inserted into the pleural space, a Seldinger technique. With the wire in place, a counterincision, medial and inferior to the insertion site, is made, and using a plastic tunneler attached to this Pleurex catheter, the catheter is drawn through this tunnel. The catheter is then placed, this Teflon cuff is then placed within this subcutaneous tunnel, about 1 centimeter from this opening. One can see it being pulled through here. The wire remains in place. Once that's done, an introducer with a peel-away sheath is placed over the wire in the direction of the wire so as not to impale any thoracic organs. Once this is in place enough, the obturator and wire are removed, and typically there is a gush of pleural fluid. Thumbs used to occlude this space. The patient continues to breathe normally. The fenestrated portion of the catheter is then placed through this peel-away sheath into the thoracic cavity. Once this is placed all the way in, the peel-away sheath is removed, and this is sutured here. It is secured with a suture here at the skin site, and then the catheter is accessed for drainage of the fluid. This is the obturator into the one-way valve to drain the fluid. This shows a schematic with the obturator going in. There's a small click which allows this to be stabilized during the drainage process. Fluid can be drained into a vacuum bottle, into a suction canister, whatever. This is used to control the rate of flow. Once the fluid has been drained to completeness or to an appropriate volume, or until the patient has pain or cough, it would be then concluded, and a dry dressing is placed with an occlusive tegaderm-like bandage. The follow-up for these catheters is typically quite simple. A chest X-ray is done to identify location, absence of pneumothorax, no injury. There's a video for the caregiver. Both written and oral instructions are provided. Pain medicines. Drainage at home of approximately 1.2 liters per 24 hours is recommended. There is a drainage guide that's provided to the patient and the family with the date and time and the volume that is drained. Follow-up is clinically indicated, and catheter removal typically when it has been clinically dry for approximately 1 week. This was the histology from the study. The 99 patients with the Pleural catheter, 40% lung, 25% breast, 35% other, and was essentially the same in the chest tube and sclerosis group. Outcomes were control of the effusion, hospitalization, morbidity, and survival. Evaluation was a dyspnea scale and a quality of life questionnaire, as well as performance status. Any positive number here is an advantage. So it is an advantage compared to baseline. So when one examines chest tube and sclerosis and the Pleural catheter at 30, 60, and 90 days after treatment, one sees that both had advantages in the respiratory function of these patients, whether at rest or with exercise. Both were significantly advantageous. There was a statistical difference between the Pleural catheter and chest tube at 60 days exercise compared to rest, but this may just simply be measurement itself. The chronic respiratory quotient questionnaire scores, again positive values, showed equivalency in effect between the chest tube and sclerosis and the Pleural catheter. The morbidity was equal between the two groups. The chest tube, some fever, hydropneumothorax, and other. The Pleural catheter, fever, pneumothorax, misplacement, and other. There was no treatment-related mortality. There was no intra-procedure catastrophe that required operation. Pleural synthesis was achieved in 71% of those individuals having chest tube and sclerosis. Of those, 28% recurred. For the Pleural catheter, 69% achieved pleural synthesis, and there was no recurrence. Median survival was 90 days in both groups, and a poor survival overall, reflecting the end-of-life decisions that are made for the care of these patients. And this shows the survival curves. 90 days and no statistical difference. The observations were that the chest tube and the Pleural catheter both improved dyspnea, that the Pleural catheter had equivalent safety and efficacy as chest tube and sclerosis, and the median hospital stay was quite short, a 1-day median versus 6.5 days median in the chest tube and sclerosing group. Thought being that perhaps this could be done as an outpatient and preserve bed days for patients of higher acuity. The economic impact was examined over the initial 7-day period. 100 patients with the Pleural catheter, 40 as inpatient, 60 as outpatient, and a concurrent group of 68 patients. These were sequential patients over approximately a 24-month period. They were not selected other than by the treatment received. So this is not a prospective study. It is a retrospective review of a cohort of patients. The histology was about the same as before: lung, breast, and other. Lymphoma included about 7% of these patients. Cytology was positive in 75% and either negative or unknown in 12% respectively. There were no catheter-related deaths, no operations, no major bleeding episodes. The morbidity in 81% were none. 19 patients had one or more, including recurrence of fluid requiring treatment, infection, occluded catheter, and other. And this just reflected the expanded use of this catheter in other patients. The mean length of stay, of course, outpatients had no length of stay, 0, 68 patients. Inpatient Pleurex catheter, 40. Chest tube in 60 patients, showing about 8 days median for both. There was no advantage for the patients with the Pleurex catheter. If one examines the economic impact, chest tubes $7,800, inpatient Pleurex catheter $1,100, outpatient Pleurex catheters $3,300, showing a significant financial advantage to an outpatient management. Plus the patients were home. The conclusion was that outpatient Pleurex catheter drainage was safe and cost-effective, high success, minimal morbidity, good patient and good family tolerance, in that the family and patients intervened against their disease. It did give them a degree of psychological control over this morbid problem. And the pleural catheter drainage could be considered a standard method for treatment of malignant pleural effusion. Bill Warren from Chicago recently reviewed this and presented this at the STS. 200 patients, 232 Pleurex catheters were inserted, which included bilateral and replaced catheters. 15% of these patients died within 30 days. If one examines the histology, breast, lung, GYN, and miscellaneous, there was a significant portion of trapped lung in these patients. A number of patients died with the catheter in place, and a number of these individuals who had longer-term survivals did have the catheter removed within a short period of time. If one examines the Pleurex catheter-related events in this cohort of 200 patients, 2% infection, some occlusion, some drainage more than 100 days, and recurrence. Now, obviously, if one could pick out these patients early on, perhaps an alternative therapy such as thoracoscopy, tout sclerosis could be certainly considered. But the recurrence in these patients were only about 2%. If one does have a trapped lung, you drain the fluid, you have this residual space, that you can use this type of catheter, drain the fluid, and allows the non-involved lung to work better by providing a degree of mediastinal shift. The advantages, it relieves of this Pleurex catheter, it relieves or eliminates dyspnea, optimizes function, can eliminate hospitalization, and minimize cost. This can be placed and removed with local anesthesia alone. Patient care is provided at home, and they intervene against the disease. Disadvantages are that the drainage bottles, while relatively costly for long-term use, are balanced by its ease of use by the family. It does require drainage every other day. There is a device both inside and outside the body with the potential for infection and for loculation. So does the Pleurex catheter meet our treatment goals for malignant pleural effusion? It does relieve or eliminate dyspnea, optimize function, as was shown in the study, minimizes hospitalization, and minimizes cost. As pleurodesis is an artificial measure and hospital-centered, the Pleurex catheter can provide a patient-centered relief of dyspnea. So the questions that have to be asked are Pleurex catheter or TALC with hospitalization. I think the patients and families are enthusiastic about outpatient management, as are the medical oncologists. Pleurex catheter can be used in benign effusions, but it tends to be more long-term, and a balance between cost and benefit must be considered. Occluded catheters are easily removed, and one can reinsert them or consider thoracoscopy. I appreciate your attention. Thank you very much.